Hey guys, I'll give people a few more minutes to filter in. Um, People may have also forgotten because we pushed it forward a week and stuff, but
Yeah, I just sent out a text to everybody, so we'll try to get some people on.
yeah, no worries. Otherwise, we can have a small mini lecture just for you and Eric and Carolyn.
Love it. Oh, Dr. Divi, remember that? I don't know if you got the notification in your email, but that paper we submitted to the Spine Journal back in December on like the fellowship, grading the content of the fellowship websites.
Yeah, right.
That actually got accepted without revisions.
I saw that for the Spine Journal.
Yeah.
That's amazing.
How wild is that? Like,
I saw that. Yeah, it was like Mark Plant submitted some thing, and I was like, wait a second, does this mean it was accepted?
Yeah, so wild.
It's really interesting what reviewers like decide to accept and not. Like, you could spend a lot of time doing like some really complex thing that gets rejected because people don't understand it, but this was a good one that's just a kind of like a quick update, right?
Yeah, no, exactly. Yeah, it was basically a 5-year update. And I think what really helped was that like we like basically just was like praising NAS and their like fellowship,
Yeah, that that definitely helped.
Yeah, so it worked out.
How's it going?
Good job on that paper, Eric.
Hey, thank you, Dr. Patel. Appreciate it.
A few more to go here. Why don't we do this? It's 5:32. Let's give a couple more minutes and then we'll press on. So we moved the time frame back to 5:30. Sri, thanks for being available. Just because that's the survey we sent out like last month basically said that Wednesday still worked, but maybe let's push it back an hour. And 5:30 was like the overwhelmingly most popular time. So we'll try this for a little while, make sure that it's working, and just see if we can keep pulling folks back into the conversation a bit. So good to see everyone again, albeit virtually. Hemel, how are you?
I'm doing really well. I don't know if you can hear me. Can you hear me?
Yep, we hear you loud and clear, bud.
Yes. I just realized that. Meet Neil.
Oh, hi there.
Hi, buddy.
We are trying to teach him how to swallow.
Oh my goodness. All right. Well, that's maybe a little more important, but thanks for signing in anyway.
Absolutely. Yeah, I'll be a silent spectator, listener.
No problem. He'll learn as well. He'll be the next generation.
Yes, absolutely.
All right, Humble. Nice to see you. Okay.
Same here, Dr. Patel.
All right. Sri, do you want to go ahead and take it away? Dr. Divi is going to talk to us about acute cord injury today. We'll go through your slide. Maybe we'll have some good Q&A along the way.
Yeah.
Sri, if you're open to it, we can interrupt anytime, right?
Yeah. Let's just have an informal dialogue, I guess.
Okay.
All right, let me pull this up. All right. So, I told the residents this, but so, I was finishing up fellowship. It was like June, I think, and I was last week of June. I kind of finished in my room. I go over to my co-fellow's room. He's like in some case, attending's not there, and he's like kind of deep, kind of in his own thoughts. And then there's like this other guy standing there waiting to talk to him, just like not saying a word. I was like, this is kind of weird. And I looked at him closer. I was like, oh, I kind of recognize him. He was a med student who'd done a rotation with us before. Now he's back as the intern. He was like kind of timid, and he was like waiting to present this MRI to my co-fellow who was on call. And I took a look at it. I was like, well, yep, that's a problem. That's cord is taking a 90-degree turn. And so it was kind of like a fresh, like running start for this intern evaluating like an acute spinal cord injury.
Yeah, that's not something that you want to hold on, right? So, hey, real quick, Hemel, I think you're unmuted, so we can hear you, bud. No problem. There you go. All right, bud. So yeah, that's a good picture there.
Yeah, and it kind of shows you a classic like flexion distraction injury with acute spinal cord compression. So we'll just give it a quick outline of the talk. So we'll talk about epidemiology of spinal cord injuries as well as pathophysiology. Talk about treatment of acute injury. The role of steroids, MAP goals, surgical timing are all three important questions that are always coming up. And then more importantly, in terms of like where a lot of research is focusing, mainly basic science research, is neuroprotective agents. There's not much we can do for the acute injury, meaning the primary insult, because that's the trauma. Now, the goal is to decrease the secondary insult. So the epidemiology is globally, it's hard to know for sure because reporting is scarce. The best data actually comes from North America. And we have in the USA at least 54 cases per million people annually. That results in 17,000 new cases per year, at about 500 cases for the Chicago metro area, if you kind of just do the math for the population. To about 282,000 are living in the USA with spinal cord injuries. And they tend to be males. And interestingly, over the years, the median age has increased and is expected to continue to increase. So many different etiologies for spinal cord injury. Still, the majority are vehicle accidents. As we get elderly population, then falls are also causing increased rate of spinal cord injuries. We can have penetrating trauma that causes spinal cord injuries as well. And then lastly, but we shouldn't forget, if we're covering, sports, football, hockey, all kind of high risk. Any collision sport, again, is high risk for cervical spinal cord injury. The majority result in incomplete and then less so complete injuries. And these stats kind of show the lifetime costs here on the bottom right for a high tetraplegic versus low tetraplegic versus an Asia level D. So the tetraplegic, as you can imagine, it's in the first year, it costs a lot, $1 million plus. And by the time they're 50 years old, 50 years later, it's 2.6 million. A patient who is 50 years old can expect a lifetime cost of 2.6 million versus a 25-year-old, which should be 4.7 million. So it's a pretty high cost. The occupational status of the injury victims, about 20% are employed at the time of injury, and then 35% are employed 20 years after the injury. So there's some recovery there. So as we talked about, the primary injury is due to a mechanical failure of the spinal column causing a cord injury. And what happens in this primary insult is you get a disruption of, the primary axons surrounding blood vessels, as well as the primary neurons, the primary cells, as well as the glia, the supporting cells. Then you get generalized swelling in the cord with hemorrhage in the gray and white matter tracts. So the secondary injury we talked about is, let's say you reduce a person with a dislocation or stabilize them in a collar, you're still going to continue to get further injury at the spinal cord. This is mainly due to vascular dysfunction, and then ischemia-related edema, and then a release of multiple cellular factors and cytokines that cause excitotoxicity. You can have electrolyte shifts that cause depolarization and increased excitability of the neurons. Free radical generation from a lot of cell apoptosis causing further damage. So all of this causes further damage to the spinal cord after you even stabilize the initial injury. The final kind of pathway, after this inflammation resolves, is that there actually becomes sort of cavitation, or like a cavity that forms within the spinal cord, and then glial fibrosis. So the supporting cells kind of scar down and try to repair, the injury with scar. So the spinal cord, different injury types, we can largely classify them descriptively based on the level of injury as well as their functionality. This is why the physical exam is so important. And then, we classically learn about these tracks, the relevant anatomy, the functional anatomy of the spinal cord, to kind of make sense of what's going on. So, briefly review, complete spinal cord injury is a permanent lack of function distal to the level of the injury. So there's no sensory or motor. Incomplete is there's some residual function distal to the level of injury, whether it be just sensation or a combination of sensation and motor. And there's different incomplete spinal cord syndromes. So central is the most common. You can also have anterior cord syndrome, posterior cord syndrome, Brown-Séquard. And then conus medullaris occurs at the thoracolumbar junction, so just at the tip of the spinal cord. And then cauda equina is obviously lumbar nerve root and sacral nerve root compression, but that's also kind of like an incomplete nerve injury. Sorry, to go back, I just want to talk about like the anatomy of the spinal cord itself. So the gray matter is butterfly shaped or H-shaped, as you know. These are the dorsal horns, these are the ventral horns. They're paired ventral horns, and these contain the motor neurons and interneurons. The white matter surrounding it contains all the ascending and descending tracts. So you have like the dorsal columns over here, which are responsible for vibration and proprioception. You have the ventral spinal thalamic tracts, which are responsible for pressure, crude touch, and then the lateral spinal thalamic tracts that are responsible for pain and temperature, as we classically kind of think about that. So, you can imagine an injury to the cord in certain areas would theoretically cause, lack of pain or temperature, or lack of motor function, or lack of proprioception. So with this incomplete spinal cord injury central cord syndrome was termed as such because people noticed initially, this was back in the 50s or so, the initial people, I think it was Schneider who described it, that people fall and experience a hyperextension moment to the cervical spine, pre-existing spondylotic spine that with the narrower canal, with increased ligamentum flavum hypertrophy in the back, just less room in the canal for the cord, then gets acutely pinched or compressed, and then goes back to kind of its normal state. There may or may not be a fracture and associated instability, but the resulting spinal cord syndrome is more prominent upper extremity weakness than lower extremity. And whenever you notice that, that's what people term central cord syndrome. And the initial thought was that this is because of, that the center of the spinal cord is more affected, and therefore motor tracts, which are more along the ventral horns, are affected disproportionately in the upper extremities compared to the lower extremities, because the lower extremities would be more laterally located. But interestingly, talking to actually Dr. Fellings from Toronto, who does he's a neurosurgeon, does a lot of research in basic science with this kind of stuff. And in their literature as well, it's been shown that all these tracer studies, that it's not really laid out somatotopically like that. It's more complicated. And while that was originally described for the dorsal columns, it may not be true of these, spinal thalamic or the motor columns. So it might be a misnomer, but for now we'll go with that terminology. Anterior cord syndrome, we classically think about as a vascular injury because it affects the anterior 2/3 of the spinal cord. Often from, if you think about, let's say, injury to the artery of Adamkiewicz or anterior spinal artery, you lose motor function as well as pain and temperature distal to lesion, but you have preservation and proprioception because your dorsal columns are still in touch. You can also have vibratory sense in that 2-point and fine touch.
Hey, Sri, the central cord is probably the one that's still controversial, right? And I think thanks for highlighting some of those limitations in the thought process around central cord.
Yeah.
I think the other way the other term that's been used more commonly, although not as frequently as central cord, but increasingly so, is acute traumatic myelopathy, which it's just as vague if you think about it. It's acute, from a trauma, and myelopathy just means cord disease. But the idea is, in some respects, it's an acute worsening of the sort of chronic myelopathy that we sometimes otherwise see.
Right. It's like there may or may not be a pattern towards motor and sensory loss, but there's some dysfunction. Right.
Myelopathy, when we think about degenerative myelopathy, there's not always a pattern per se. There's generalities. It can affect balance. It can affect hand function, right, more than other functions, but it's not like there's a textbook answer for what a neurological picture looks like. And that's sort of what we see with central cord / acute traumatic myelopathy.
Right. Yeah, actually, I like that term better, actually. Posterior cord syndrome is It's more rare, and I've actually never seen it, but it theoretically is loss of proprioception, but preserved motor function. Brown-Séquard, again, I've never seen it, but theoretically can be caused by sharp hemitransection of the spinal cord. And what happens is if one side is affected, then you have ipsilateral loss of motor function because the ventral horns are affected, and so ipsilateral loss of vibratory sense and proprioception because of the dorsal columns, and then contralateral loss of pain and temperature because of spinothalamic tracts that cross over 1 to 2 levels below.
And that's like a perfect board question or
Exactly.
a training question.
Right.
In 15 years, I've seen one person with a Brown-Séquard, and yet I would imagine it's been on countless tests that I've taken over the years.
Exactly. What was the mechanism for that guy?
Gunshot.
Gunshot.
Yeah. Hey, if everybody could just check that they're muted, just so we minimize some of the background noise. Feel free to come off of mute anytime if you have a question and interject, but if everybody could just double check that they're muted for the background noise.
And then finally, conus medullary syndrome is an injury or compression of the distal aspect of the cord around the thoracolumbar junction, which typically results in bowel or bladder dysfunction, sexual dysfunction, loss of sensation in the perineum, and mild motor symptoms in the lower extremities. Cauda-Equina syndrome, as we all know, is a constellation of symptoms that can result in bilateral extremity pain, weakness, variable sensory loss, can be asymmetric, but is usually associated with some form of bowel or bladder dysfunction, whether that's retention or incontinence. So surgeons were kind of at the front line in terms of like treatment of acute injury. So our goal is to, stabilize the spine, fix any mechanical instability, and also at the same time decompress the spinal cord and give it, if there's persistent stenosis, and give it the best chance for recovery. One thing is like you have to be cognizant about recognizing patterns of instability that may be subtle because if you think about it, like I talked about in that lecture yesterday for you guys, was like that White and Punjabi definition is instability is defined as, physiologic loads that disrupt spinal column that cause further neurologic injury. So if you're going to have further cord or nerve root injury, you're unstable. Now that we'll just go over like the medical treatment. So we talked about all the surgical treatment kind of stuff yesterday, a little bit, touched on it. It's a pretty complex topic, but we'll talk about the medical treatment of it. We'll go over corticosteroids briefly because I think you guys should know the reasoning behind it. But for most surgeons, this is not, it's kind of like been studied and beaten to death. But methylprednisolone is the one that's most highly studied, even though here, on the floor, we may be administering dexamethasone, so a slightly different steroid. But this was chosen because of a reduction of membrane lipid peroxidation and possible beneficial effects on blood flow and neuronal excitability. The first one, NASCUS-1, was published in '84. It had 256 patients, compared low versus high dose. And the low dose was 100 milligrams bolus and 25 milligrams Q6 hours. The high dose was 10 times higher. And then this was administered for 48 hours. And then the primary outcome was the motor sensory exam at 6 weeks and 6 months, which found no difference. But they did find a difference in a higher relative risk in the high dose group for early fatalities, less than 14 days, or wound infections, both of which make sense in a high dose methylprednisolone group. Obviously there's limitations with this study. Clearly there's no control group, and there was very limited follow-up, about only half of the cohort, and it was pretty low number if you think about it, 256 patients. The next study 6 years later published, they finally included a placebo group. So there was a 3-arm study. They only included one steroid group, and this was a high dose group with that loading dose that we're familiar with, 30 mg per kg, and then continuous infusion for 23 hours. And then also had naloxone group, and naloxone was chosen, as you know, it's an opioid antagonist, but also may show some functional utility with some effects on blood pressure or cord perfusion, or so was thought, and so that's why it was chosen at the time. The results of this study showed that high dose group within 8 hours, if you followed them out to 6 weeks and 6 months, that group showed differences for motor, light touch, and pinprick. Now, as you can imagine, they didn't go into the study, dividing up the high dose group with, for analysis between 8 hours and 8 to 24 or greater than 24. So this was a post hoc application of 8 hours, kind of like a statistical, I guess, I don't want to say manipulation, but a statistical kind of, grouping that found significance. So this was pretty, criticized for that, because if you take that away, there weren't really any differences. Now, NASCUS 3 then looked at the duration. So, they took the high dose group and did it for 24 hours and then 48 hours. They didn't have a placebo group, but their control, their treatment control was a Terilizad, which was chosen for, again, decreasing peroxidation of neuronal membrane. Same endpoints were used. The longer group, 48-hour group, that's started within 3 to 8 hours, showed improved motor recovery at 6 weeks and 6 months. But this group also had more complications, severe sepsis and severe pneumonia. So again, pretty unclear what the risks, pretty unclear what the benefits are, and had to be weighed heavily against the risks. So, pretty early on in 2000, the neurosurgeons put out guidelines that recommended against, methylprednisolone administration, because basically those 3 studies didn't really give any good criteria or guidelines. They did give, some good, they did show that steroids can work, but they also increase complications. And some of these complications, we mentioned, but GI hemorrhage, wound infection, PE, pneumonia, sepsis, and death rate due to respiratory complication. The AO Spine put out guidelines in 2017, and they suggested within 8 hours, you can consider doing a 24-hour infusion to treat. But again, this had very little evidence, as it was a weak recommendation. And then definitely no 48-hour infusion. And then over 8 hours, again, think twice about giving steroids. I think my takeaway from steroids is, for older patients who are maybe at a high risk for the complications mentioned before, I would be very wary of giving steroids. If there's a clear, for younger patients who had a clear trauma, high mechanism trauma, things like that, I would be a proponent for giving steroids, because I think it's beneficial, if given within this 8-hour window. Then there's a huge kind of, middle ground that you can go either way. But I think overall, I would lean away from giving steroids. Again, if there's, some event that you can trace to, and you can administer steroids right away afterwards to decrease cord edema, then I think it would be reasonable, but it has to be weighed against the risks. I don't know what your guys' thoughts are.
Yeah, I think we're in the same boat where our default is to not give steroids, and that's across both ortho and neuro. I think some of our surgeons, our faculty, will go with steroids in those unique settings. Young patient, non-penetrating injury, acute onset, saying, well, I'm not sure about the benefit, but I think the risks are manageable, right? Whereas in the older population, the risks become really quite problematic. So
Right.
I think the general answer is no, we don't do it. And I think you did a good job of pointing out the limitations in the data. I will tell you what's interesting is, and I'm curious where this is going to go in the next 2 to 3 years. So that data from all those studies has been held private for the better part of 30 years, right? That was all industry sponsored. The folks who make methylprednisolone sponsored those studies.
Right.
And the lead author on it, as well as whoever ran the studies, kept the data private. I think the Toronto group now has access to the data.
Really?
And I think they have a philosophy that steroids are beneficial. And so I think we're going to see some studies come out likely supporting the use of steroids. So we're going to see this pendulum start to come back again a little bit. It won't go all the way where it was before, where people were getting steroids by EMS at the site of injury before you knew what was going on, but you'll see some swing back to it. So let's watch the next 12 to 24 months.
Interesting. It's good to know. Then the next thing we always kind of consider right away is maintaining MAP goals, mean arterial pressure. And we always aim for 85 to 90 for about 5 to 7 days. There was a level 3 recommendation by the neurosurgeons with their society for 7 days post-injury. And this is coming from a 34 patient cohort that they followed for 30 days post-operatively. In their study, they showed patients that had greater than 1 Asia group improvement had much higher sustained average pressures, around 95, whereas the ones that had 0 improvement, and interestingly, the one that had 1 motor grade improvement were actually, to me, just eyeball test looks a little bit lower. And then, so it's, again, not great evidence, but it theoretically also makes sense. One of the interesting things to think about is people with chronic hypertension, they could be an independent risk factor for poor or early neurologic recovery. It, again, theoretically makes sense. You have a chronically hyperperfused cord, and if you undergo temporary hypoperfusion, you may have kind of like under resuscitation for your cord. So these people may necessitate a higher MAP target. So this study at shock trauma, sorry, no, it was not shock trauma. The study looked at 105 patients prospectively with cervical and thoracic cord injuries and showed that episodes of hypotension didn't adversely affect Asia motor scores. But I think they didn't have any long-term follow-up. They only kind of monitored their motor exam while in-house. So it didn't really have any good, sort of long-term follow-up on their neurologic function. So we don't really know, at least they can say that, while maintaining MAPs in-house, any periodic episodes of hypotensions may not be acutely deleterious.
Hey, Sri, how do they define episode? Are we talking about seconds, minutes? I mean, how, do you know?
Yeah, that's a good question. I have to look at the study. I would see. I think it was a period of minutes.
Yeah.
But I'll have to look at that.
Anyway, I'd be curious. I think this is interesting, but again, the number in each category is so small that I don't know that you're going to detect the difference.
Right. Yeah.
And I will tell you again, I've seen patients who get uncontrolled hypotension post-operatively and they've lost function that they had before. So again, the risk of pushing MAPs above 85, 90 really is in a subset of patients probably with cardiac disease, ischemic cardiac disease. And might you be stressing their heart too much? Other than that group, I think we really should push hard. And if they need pressors, they need pressors. And ideally you'll get, you would go on I'm drawing a blank on the term, but you don't want vasoconstrictive pressors, right? You'd want adrenergic pressors to kind of get the heart pumping a little harder.
Right.
That's at least how I look at blood pressure from a spine surgeon's perspective.
No, I think that makes sense. You got to increase pressure with perfusion.
Yeah.
And then finally, another study looked at MAP maintenance and in penetrating cord injury, and that may not have a significant impact. Again, this is a very small cohort, 14 patients, penetrating injury. And they found that, compared to blunt injuries, they showed less improvement, and that 10 out of 14 experienced cardiogenic complications. So given the poor prognosis and high complication rate, they decided against this in penetrating spinal cord injury. So then the last thing kind of comes that also is in our control is surgical timing. And the major study that looked at this was Staskis, and this was done in 2012. And it's currently kind of our best evidence that we have that looks at early intervention, which is defined as less than 24 hours And then it showed that patients that had surgery within 24 hours had a 2.8 times higher chance to have a 2-grade improvement with their ASIA score, and a 1.4 times higher chance for at least 1 grade improvement. As you can see, the limitations in this group are that the early and late groups, are they the same actual cohort? The earlier group had a higher numbers of ASIA A and B scores. So, there's some effect of patient selection there. Obviously the more severe injuries are going to go quicker. And the ASD patients also get improved to AIS grades. So then there were more of those in the late group, which then artificially skewed their analysis. So again, I thought it was a decent sized study, 313 patients, but this is the sort of best evidence that we have so far. And it, again, clinically makes sense. The Canadian spinal cord injury study also put out 470 patients that underwent surgery within 24 hours or greater than 24 hours, and their final endpoint was 3 to 6 months after injury. And they showed that ASIA A patients had no meaningful improvements, but those with ASIA B, C, or D injuries had a 6-point motor score improvement and a decreased length of stay from undergoing earlier treatment. And 2017 AO spine guidelines suggest that for kind of the same as, the same time as the steroid recommendation came out, that early surgery be offered to adults with acute spinal cord injury. And again, though, however, the strength of the recommendation is weak because the quality of the evidence is low. I think from my standpoint, I would tend to believe in this early decompression, even though that there's limited data. I think it makes sense given, you have obviously taken into several factors, including the mechanism of injury and the the age of the patient, other comorbidities, and ability to go to the OR. But if possible to do it within 24 hours and to stabilize the spine for an unstable spine, I think makes sense. And finally, neuroprotective neuroregenerative strategies are kind of the next frontier. And this is kind of goes along with this classic saying that I always used to hear is like, it's a great time to be a rat with a spinal cord injury because there's all these options available. The clinical trials that have been done have not really shown great promise yet, but that doesn't mean we shouldn't stop trying. And then something on the horizon may come where, we actually might be able to get good, not only neuroprotective agents, but regenerative agents. So one of the ones that was initially studied was minocycline, and you may know that as like a tetracycline antibiotic. It's actually able to cross the blood-brain barrier, and the way it works is prevents the caspase pathway from being upregulated, so therefore it kind of decreases the apoptotic pathway and decreases secondary cell death in the spinal cord. These clinical trials initially demonstrated utility in the ALS in humans, and then mouse models of Huntington's disease. The rat spinal cord injury model seen here towards the right, you can see that tetracycline was used as a control, and minocycline as the treatment. You can see at the lesion level in the middle column, there's increased scarring and cavitation forming in the control group versus in the treatment group. There's relative preservation and not as much apoptosis, and that's also been shown with immunohistochemistry and with histopathologic slides. Finally, so there was a phase 2 placebo-controlled study that was started. This is currently, I think, in phase 3 as of 2018, but no published results yet. The phase 2 study results showed that 52 patients that were in it, 6 points higher motor recovery in the minocycline group overall. So pretty promising, but again, that's a very small phase 2 study. Phase 2B study and a bigger phase 3 study needs to be done. Riluzole is a sodium channel blocker used for ALS treatment, and it's been evaluated for spinal cord injury because it decreases neuronal excitability by decreasing release of glutamate, so decreasing excitability of neurons, and then also helps to maintain kind of cellular ionic balance. In ALS, it's actually been shown to improve survival for 2 to 3 months for those patients. And animal spinal cord injury models have shown promising behavioral and functional outcomes following spinal cord injury. The RISCUS study was done to, it's currently underway, the phase 2B and 3 trial nationwide, and I believe it's supposed to end like in 2025, so there's still a while to go, and I don't know how many patients they've had recruited yet, but this is evaluating the effect of systemic riluzole on cervical spinal cord injury in the subaxial spine. So the phase 1 data demonstrated significantly larger improvement in motor scores at 90 days in the riluzole group. So potentially some promising data there. Then there's another pathway that was targeted. It's called the Rho-ROCK pathway, and this is upregulated in spinal cord injury. And this actually inhibits axonal growth. So an inhibitor that targets this pathway would theoretically kind of allow regeneration. This was initially done as a small phase 1, phase 2 trial with 48 patients and with extradural application. And this showed about a 2.7 point improvement in Asia score in cervical injury. And then more recently, I guess this was in 2018, yeah, the company that started the study halted the phase 2B trial because basically there's a futility and they, no promising results going forward, so they just pulled it. And then finally, another promising pathway for targeting is this repulsive guidance molecules that kind of limit repair for neurologic recovery. So monoclonal antibodies that block these effects can enable sort of axons to regenerate and rebuild myelin. And AbbVie developed one called alezenumab that neutralizes these RGMs. So another exciting kind of pathway. And then this showed in a thoracic rat and cervical spinal cord injury model some promising results as well. Finally, self-transplantation in thoracic spinal cord injury. This would be kind of along the neuroregenerative pathway, and would theoretically make sense. You want to implant kind of autologous stem cells, or autologous either mesenchymal stem cells or Schwann cells that kind of support the neurons to kind of regenerate as you would, let's say, a peripheral nerve. But again, this is a lot easier said than done. And although there's been no adverse events in kind of initial studies, that there hasn't been any good sort of longer term studies clinically with these. Another interesting aspect is looking at, for example, a hydrogel type scaffold that can kind of provide a bridging area for like the zone of injury. So this is a PLGA. PLL is a bioresorbable polymer that kind of promotes healing and then spares white matter and decreases the cyst formation. So there's currently one trial underway that has enrolled 2 patients, the second 2.0 trial. The 1.0 trial that enrolled about 16 patients. Supposedly 7 patients had Asia score conversion in about 6 months. This shows a picture of how this is implanted. So it's pretty invasive. This is the dura that are retracting, and it's an intralesional or intramedullary implantation of the scaffold. And histologically, this is what it's designed to do: take the cyst and kind of decrease it. So in conclusion, it's, acute spinal cord injury is a devastating problem with a significant societal cost. We're kind of at the forefront, and we need to manage patients with early intervention, whether it's medical intervention or early surgical intervention to decompress and stabilize. Then there's possibility and promise of a lot of other things coming up in the market via medical and pharmacological treatments. But I think there's still a lot of investigation to be done on that front. So as of right now, we just kind of have to do the best, clinical treatment that we can. And hopefully in the future, there'll be more options.
That was awesome, Sri. Thanks for putting that together. I think kind of like high level take home points, and then it's open mic for questions is just, as we see these patients in real time, let's understand that, time is of the essence, right? And that our goal is to be as quick and as definitive as we can be for these patients. So when you tell that story at the very beginning of the intern waiting to tell someone about the cord injury, that should not be how we do this. That sort of should be how we move. We move a lot faster, and you sort of run things up the chain quicker rather than waiting.
Right.
And then I think for everyone else also then is oftentimes, we're talking about pre-op and post-op medical management of these individuals, right? They're sick, they might be polytrauma, but we want to take pretty hard ownership over their cord injury, which is why oftentimes we pull for these patients to go to the neuro ICU, and we ask, sort of for critical care to manage these patients. My experience in the past is that, when folks are sort of being primarily managed by other services that aren't sort of focused on the neurological function, mean pressures, and perfusion for their cord might not be the most important thing on their list. So let's make sure, again, the other reason to take strong ownership on these patients is to manage that post-injury, peri-injury, perfusion situation. But what questions do we have from the residents or from anybody on the line?
Yeah, appreciate the lecture. I do have a quick question about, you talked about mechanism and how that might play a role in terms of whether or not you go to the OR for an incomplete cord injury within 24 hours. Is there a difference for you in terms of blunt versus like penetrating, trauma for those that have an incomplete cord injury? And does that influence your decision to go to the OR or not?
Yeah, most penetrating spinal cord injuries are not, in my experience, like not amenable or would not benefit from going to the OR. If there's like I can imagine, for example, what I'm trying to get at is like you take a person to the OR for stabilization of an unstable spinal column and also decompression, with stenosis. In penetrating injury, that's usually not the case. The damage has been done, and potentially or theoretically, you can open up the canal and give it more space to kind of allow for some cord edema. But I find it hard to believe that or acting acutely on a penetrating trauma would be beneficial. But blunt trauma, I definitely believe. I think there's good evidence for acting quickly on that. And kind of as we talked about, it all really depends on, one of the things I was trying to get at when I was saying that was, let's say if you have an older person who falls, has a hyperextension injury and a central cord syndrome, and they don't have an actual fracture on MRI. So there's no, spinal column instability, but they suffered, a spinal cord, what was the other term? Acute traumatic myelopathy. So if they experience that something's went on with the cord, but there's nothing you're going to fix in terms of stabilization or decompress if there's not much stenosis. So in that case, I would think you can kind of wait on the patient, see if their motor exam improves, then consider taking them at a later time point. Yeah, that's kind of my thoughts.
Totally agree. If when we say penetrating, let's be really clear, because we're in Chicago, we're talking about gunshot wounds, right? Very rarely you'll see a stabbing injury or something like that to the spine. So we're talking about gunshot wounds. I guess the way I look at it, Eric, also to build off of what Dr. Divi said, is to say, in all manners of cord injuries, we're making implications about the nature or the amount of force that was applied to the cord, right? In blunt trauma, car accidents, it's a little bit more nebulous, right? We're not sure exactly how much blunt force injury the cord took. So we're sort of saying, let's give it a chance by getting it decompressed, getting it realigned, and hoping that we see some improvement. In penetrating gunshot wound trauma, there's actually quite a bit of data showing the amount of energy transfer, right, that occurs internally after a gunshot wound. And there you've got a completely different situation where you've got a substantially greater amount of energy that's been transmitted to the cord. So to Dr. Divy's point, the damage is done, if you will. And on top of that, very rarely do we see instability associated with blunt trauma. If you do, I think we would treat those patients from an instability standpoint surgically, but not so much from a standpoint of let's get them to the OR in hopes that we can improve their neurological function.
Most definitely. Thank you very much.
There's another question. Somebody else was speaking up.
Yeah. Hey, Dr. Divy, thanks for the talk. I just had a quick question about medical management and chemoprophylaxis, especially like in post-surgical patients for spinal cord injury. The number that I've heard discussed usually is 72 hours. And then I know some people say, maybe you could do within 24 hours. I don't know if you had an opinion on that or what your thoughts were.
Just for DVT prophylaxis, yeah.
Exactly, like risk of post-op bleeding, and then weighing that with the risk of VTE in these patients who may have, spinal cord injury.
It's highly variable, and I think that's a great area for a study. I'm personally okay with 48 hours after, and that's only because I picked that up from training. But there's people I think neurosurgeons tend to wait a lot longer, and tend to be a little bit more aggressive. But this is all anecdotal. I don't know anything evidence-based wise to support one way or the other. Most people would tend in the cord level just to wait a little bit longer than, let's say, lumbar spine. Lumbar spine, I'm fine with, generally like heparin, like post-op day 1. But cervical or thoracic cord stuff, I usually wait till post-op day 2 or longer.
Yeah, we don't have consistent guidelines to support one time frame or the other. I think actually for us, Sri, the neurosurgeons move faster than we do. I think they're usually anticoagulating, their elective patients within a day. And
really?
I think cord injury patients even faster. Yeah. I've just seen enough hematomas that it gets me worried, which is why we waited out a few days. And I think, I don't know whose comment that was. That Peter? I think Peter.
Yeah.
Yep.
It was that 72 hours is probably something you guys have heard because of me, not necessarily because of a ton of evidence. So this is a question mark that we don't have good guidelines to guide us on, if you will. And as Sri mentioned, it's probably worth looking at. A lot of the larger retrospective studies that have been done, whether they be single center or like large multi-center or administrative databases, it gets really cloudy in terms of exactly what's their definition of a VTE and what did they use for chemoprophylaxis. So unfortunately, the existing evidence is there, but it's not super convincing,
Gotcha.
And again, in the acute phase, what I would do is, most of these folks are in the unit. We're watching them pretty carefully. We've got SCDs on them, so you're getting some systemic effect from that. And then day 3, we would start them on an anticoagulant in hopes that they don't still develop a hematoma, but giving them a few days, 72 hours to at least clot whatever they can clot in the surgical bed. But the VTE risk is so much higher for these patients that these are folks where, I maybe even think more aggressively about longer term management. And usually the cord injury folks take that over and they run with it pretty well. Where these folks are anticoagulated for months and months after a cord injury.
Mm-hmm. Yeah, makes sense.
Gotcha, thanks.
Yeah. I got another question via chat with Michael. It says, why do we treat cauda equina as an emergency while we don't treat other nerve root compression with urgency? And I think that's a good question, and probably took me a little while to wrap my head around, but I think cauda equina can be thought of as like a progressive nerve root dysfunction that can result in like permanent damage. So like, for example, if I think of like a unilateral nerve root compression, like if you're having progressive foot drop, things like that, like I guess depending on the severity and how long it's been there, there's a chance it can come back even if you wait a couple weeks or 3-4 weeks. But there's studies that have been done on cauda equina on these lumbar and sacral nerve roots show that you wait greater than 48 hours, your recovery becomes a lot less. So I think it probably has to do with the amount of compression. Usually cauda equina cases we see are, complete compression of the thecal sac at some point. So it's kind of on this incomplete injury spectrum, even though it's not the cord level, it's the root level. But
yeah. The other way to look at it is really to say that it's a bit of dogma that nobody wants to test out, right? Nobody's going to run a randomized study to see if you wait on a cauda equina or not, if they get, if late versus early surgery in that setting. The studies that we quote are really retrospective, right? They're backwards looking, they're small numbers, but when it comes to a cauda equina, the functional impact of a cauda with regards to bowel loss, bladder loss, some degree of sexual dysfunction, and then lower extremity numbness and pain. It's just such a severe presentation that we treat it more like a cord injury versus a unilateral, radiculopathy or an acute foot drop. I think that's probably the bigger reason why. The functional implications are so much that most people would say you better just go ahead and do it. And it's so ingrained as dogma that to go against it, you take some pretty substantial risk.
That makes sense.
But it is a good question to ask, right? Why do we treat them so different if it's all nerve root?
Right, exactly. It's not the cord. It's all nerve roots.
Why is it so different? It shouldn't be, but again, it's one of those things that I don't think anybody's going to really test out. Now, that said, I will tell you, if we see somebody with an acute foot drop, if I see somebody come in with a big lumbar disc and they've got a drop foot that's relatively acute, and I don't mean just a slight grade, 1 grade motor loss, but, really substantial motor loss. Those are folks that you do move towards surgery faster than you would otherwise, but maybe not an emergency, right?
Yeah, I tend to think like a 2 out of 5 strength kind of, think about within a week or so, just try to get them in the OR.
Yeah, just get it done to give them the best chance possible. But again, even in that setting, we don't have like comparative data that says surgery gets people better. We're sort of assuming that let's get rid of the offending problem and give them, if not a better result, a better chance for a better result. But great questions, really good questions.
Good questions.
Any other? Otherwise, we can probably start to wrap up. Sri, thanks for giving 2 talks this week. I forgot that you had one yesterday morning.
Oh no, it was easy. It was along the same. It was spine trauma, so I just talked about the actual classifications and stuff like that. So
yeah, the one thing we didn't talk about tonight, and I'm not sure if you covered it yesterday, is just to know the Asia classification. For the residents. That's again fair game for in training and for boards. To make sure you know the difference between Asia E, Asia B, C, D, and E. Right?
Yeah, we went over that a little bit yesterday.
Right.
But should it be?
If there's any questions about classification, we should talk about that because that, again, it's really common to get a question about incomplete versus complete. There's questions around what's the difference between Asia B and an Asia C from an exam standpoint. Those kinds of questions come up. And then the other discussion is out of spinal shock. I'm not sure if you covered that yesterday, Sri.
Yeah, I did.
Right.
To talk about
understanding that exam in that first, who knows, 48, 72, more than that, 96 hours can be uncertain in the setting of shock, which is, I think, why even a complete injury, nowadays, we give them the assumption that they're an incomplete hiding, right, in spinal shock, and we get them to the OR as fast as we can.
Exactly, like an apparent complete. And then...
Yeah, you call it a complete, but again, in my mind, I'm almost thinking this could just be spinal shock, and maybe there's some function there that we could be trying to preserve.
Yep.
So.
And then the other concept was like the sacral sparing. It's like that might be the only
yes
area that you can detect an incomplete injury.
Great point. Yeah. And then the last thing I'll just mention briefly, and we'll talk about it more later, but it's a bit of a shout out to Dr. Meyer, who passed away recently. Dr. Meyer started the spine fellowship at Northwestern in the 80s, early 80s, and really was one of the people that helped design the national cord injury model that we have for rehabilitation hospitals. He did a lot of work. He represented Northwestern really well for a long time, but he did a lot of work on the seatbelt laws in the 70s. So part of the reason that seatbelts are required in the front seat and that we're required to wear them is because of, surgeons like Dr. Meyer, talking to the federal government about requirements. And so he did a lot of great work on that primary prevention of cord injury. So the numbers that we have now are so much different than they used to be. And now you pointed out, I think our young traumatic population is being replaced by an older, low energy injury population as well. And that also used to be the time where Northwestern would see basically all the cord injuries in the region, right? And now the reason we don't see as many individual patients coming to us is because spinal cord injuries are being managed in a lot of places. They're being managed at every academic hospital and in a number of the larger private, a number of the larger community hospitals in the area. So I think when we last checked, we probably see about 40 to 50 acute cord injuries in a year. And so it's a good number. We'll see them. You guys will see them during your training with us, but not quite the same numbers we used to see, 20, 30, 40 years ago.
Yeah, that fits with that kind of estimate of like 200 plus for Chicago.
Yeah. It's also part of what makes these clinical studies really hard to accomplish, because cord injury care is sort of being decentralized and being done in lots of places. The ability to run good research on this population is super challenging, right? We may not even hear about a cord injury patient until they're already over at Shirley Ryan, 2 weeks after their injury.
Yeah.
And unfortunately, most of the therapeutics are geared at acute management.
Yeah.
As opposed to subacute management. So if you sit back and you wonder why is the research so stymied from a clinical standpoint, A, it's just really hard and it's a lot more complicated than we think it is. And we know less than we know when it comes to cord injury, but B is just enrollment in this group is a challenge. Right. Anyway,
good
sweet. Thanks so much, guys. Everyone be well. We'll have our next one in a couple weeks, and we'll keep it at 5:30.
Yeah, I think this works out well.
All right. Take care, everyone.
All right.
Thank you.
Take care.
Thank you.